Okay. Well, if I can start the afternoon session, it looks absolutely fascinating. And I don't think we should waste a minute longer. We had to search high and low for an expert on psychosocial aspects of Marfan syndrome. And one of our speakers found another speaker for us. So we contacted Dr. Dieter Benninghoven to give a European flavor to our conference. He has had very interesting experience in a multidisciplinary Marfan clinic. He is at the Clinic of Psychosomatic Medicine and Psychotherapy at the University of Lübeck in Germany. His English is impeccable, and he has sent us a recording because his wife had very inconsiderately booked him a holiday in Crete today. So off he went with the family, but he's very kindly given us his recording.
I'm very honored and thankful to having the opportunity to giving this little talk to you and sharing my experiences about psychosocial aspects in Marfan syndrome, and the reason and the history behind it is that we offer a special kind of rehabilitation treatment for people with Marfan syndrome in our clinic here in Germany. Since 1914, we offer, every year we offer a treatment for groups of 10 to 12 people with Marfan syndrome, and we try to realize a multidisciplinary approach to rehabilitation for people with Marfan syndrome. Well, what do we know about psychosocial aspects and Marfan syndrome? Medical knowledge about Marfan syndrome has increased over the last decades and has led to substantial improvements in the management of the disease. Although the link between living with Marfan syndrome and psychosocial impairment is quite obvious to people who are familiar with the disease. Empirical data regarding psychosocial factors in Marfan syndrome is quite limited up to now. This is probably partly due to Marfan syndrome being a rare disease and the difficulty to gather reasonable sample sizes when you try to do research in this area. But I think it might also be caused by the fact that Marfan syndrome is medically quite dangerous and also life-threatening, that so far resources were allocated rather to research into managing the medical consequences and complications of Marfan syndrome than shedding light on the psychosocial aspects. Nevertheless, there is at least some empirical evidence. First, quality of life. Quality of life is, like in other chronic diseases, reduced in people with Marfan syndrome. And this is true for all three dimensions of quality of life. It's true for subjectively perceived physical functioning. It's true for the perceived psychological well-being and for subjectively perceived social integration. And interestingly, the quality of life, the perceived quality of life, is not related to the severity of the disease. We find people who had multiple operations, for instance, or are otherwise quite heavily affected, but who experience quality of life, and we also find people who are quite, actually from a medical perspective, well off, but quality of life is rather impaired in these people. From patient reports and also from some empirical investigations, we know that childhood and juvenile development are critical for people with Marfan syndrome. Being bullied and stigmatized because of their physical appearance and their sometimes reduced fitness is a common experience of people with Marfan syndrome, especially when they are in school and in their early adolescence. They experience being different from their peers, and especially in females, this might cause a disturbed body image due to sometimes visible differences. But from our own research, we know that body image satisfaction or dissatisfaction is not related to objective physical factors such as body length or number of operations, but to the extent of anxiety and depression, which are, of course, psychological factors or variables. We also know that, especially for kids, it might be quite difficult to be compliant to recommendations regarding consultations, medications, and limited movement behavior when physical impairment is not or not yet perceptible for them. And for adolescents, facing a potentially limited life expectancy, complicated surgical operations, and the danger of passing the disease on to children put probably strain on the juvenile development. So that we might conclude that the development of juvenile autonomy is probably more difficult for the young people with Marfan syndrome than it is for their healthy peers. Also, family life and sexuality are affected by Marfan syndrome. Feeling uncomfortable with one's own body might affect one's own sexuality, and family life is influenced by Marfan syndrome when parents not only worry about their own health but also about their children's health. Nevertheless, we know that about 50% of adult people with Marfan syndrome have children, and more than 50% are married or in stable relationships.
What do we know about the influence of Marfan syndrome on the professional life? Well, we know that people with Marfan syndrome have limited occupational options due to their physical limitations. And some people also report social exclusion due to physical limitations and due to visible differences, but being bullied or stigmatized is probably a much bigger problem in childhood and in adolescence than it is in adult life. People with Marfan syndrome retire earlier, but again, we do not find a correlation between severity of the disease and occupational participation or occupational or job achievements.
In terms of psychological impairment, we know that anxiety and depression are probably not generally elevated, but especially after surgery, they often increase. And we also know that psychological well-being, again, does not primarily rely on objective measures of severity of the disease, but rather on subjective coping strategies. So then the question arises, what might help in dealing with Marfan syndrome from a psychological perspective? Well, managing a chronic condition like Marfan syndrome is much easier when the affected individuals are well informed about all aspects of the disease. Especially the internet offers endless amounts of information. People sometimes have difficulties to screen and filter all these information. So it's good to have trustworthy sources like the Marfan Trust here in the UK, or the Marfan Hilfe, which is our German self-help organization. There are probably different ways of dealing with a chronic disease. One of these ways would be to gather all the power you have to fight against it as powerful as possible. But from a psychological perspective, we would rather recommend to accept what you can't change.
Sometimes a chronic disease like Marfan syndrome points a way of avoidance, such as, for instance, the avoidance of social contacts in order to be safe and by yourself.
The recommended way of dealing with Marfan syndrome instead is to accept what needs to be accepted, including all fears and doubtful thoughts, and to keep on with pursuing the personal and valued goals. Another source would be to engage in an active coping style. And that, for instance, can mean to ask for information, finding support from family members, friends, or from professionals, generally seeking help, engaging in recommended sports activities, and it could also mean to actively
make changes in personal life that need to be made in order to better getting along with the chronic disease. And it could also mean to make the needed changes in the personal environment that need to be made. What also might help is to be connected with other affected people. Being organized in a self-help group, for instance, can help in many different ways. People can share knowledge about operations, medication, about doctors and hospitals, but also about problems in daily life and how to get along with these. Regularly engaging in mindfulness practices can be a good way of purposely bringing one's attention to experiences occurring in the present moment without judgment, which might help reducing stress and getting more focused in life. Additionally, it might be helpful to clarify the personal values, which is to get an idea of what is really important to somebody, because this might help getting along with situations where reality is not the way it is supposed to be. It is easier to deal with negative situations when the overall direction is clear and meaningful to somebody. All in all, a good metaphor for what I try to say is that probably better to let the chronic condition like Marfan syndrome be a passenger on the bus of life than letting it be the driver. Now, our multidisciplinary rehabilitation approach to Marfan syndrome is the result of a cooperation between the Marfan unit at the Clinic for Cardiology at the University Clinic in Hamburg, our self-help organization for Marfan syndrome in Germany, and our rehabilitation clinic in the Baltic region in northern part of Germany. We offer a 3-week inpatient rehabilitation in groups of 10 patients in medically stable condition with Marfan syndrome. And we try to combine, of course, medical treatment, education about the disease, physical therapy, and psychological counseling, similar to what I tried to explain to you, and combining stress reduction, mindfulness, and of course with acceptance orientation. So far we could document some promising results in terms of improved physical fitness and also in terms of an improved psychological well-being, including less depression, anxiety, somatization, fatigue, and pain. Okay, yeah, these are basically the thoughts that I wanted to share with you. Hopefully it was a little bit interesting for you. I thank you for your attention, and I wish you an exciting conference. Okay, bye-bye.
That was very enlightening. Are there any questions that have arisen or comments from anybody in the audience? As far as I know, the only multidisciplinary clinics that we offer in England are ones where they combine an orthopedic surgeon, an ophthalmologist, and a cardiologist all at the same time. But because the NHS doesn't like paying several specialists to run one clinic, these are few and far between. I think Oxford probably is the best example, and they have a special clinic like that once a month, which means they can't see very many patients with that kind of concentrated care. Another question that comes up really is, at what age should psychological counseling be offered? And I've found in my experience that you have to include the family as well as the patient, starting when they're newborn, because the whole family is affected by the diagnosis, not just the child. The parents don't quite know how to relate to the baby, and you have to say to them, look, this is your baby first, and it has Marfan syndrome second. That's the correct order. So raise it as your baby. Don't be overly anxious. Work with the doctors, but share that problem. And then there's evidence from America that children up to the age of 5 years do not see themselves as different. But as soon as they start school, then they compare themselves to their peer group. And so they may start to ask questions at home. Why am I the tallest? Why can't I run as fast as the others? And so forth. So the parents have to be prepared with for this in order to be able to answer the questions. It's a bit like sex education. You don't sit the child down at the age of 5 and say, look, you've got Marfan syndrome and this is what it means. You just have to answer the questions as the child raises them, depending on their age. And then, of course, the teenage years, when they're very, very sure that they are different in many different ways. And that's a very delicate period because you don't want them withdrawing and becoming isolated, which is the tendency. And then you've got the young adult stage. What do I tell my girlfriend? I don't look like the other girls or boys. How shall I explain it? Shall I tell everybody I have Marfan? And we usually say, no, just reserve it. If you find somebody really special, tell them, and they will be your ally. And of course, before you get married, it's better to discuss it at that point. Because if, for example, you marry and have an affected child, then the partner is responsible for looking after you and the affected child. And he may feel he hasn't been included in those decisions because he didn't have all the information he needed. So it's good to talk about things at all stages. Anybody got a question or a comment at this stage? Jolly good. Well, I think we'll try and develop a bit more in this year, a bit more attention to psychosocial problems, especially with our young adults in mind, 16 to 24. That's our emphasis this year.